Okay.
I'm starting to feel like a pincushion.
Uh, that's kind of well. Hopefully, when your surgery's all over, you'll be feeling much better. All right, let's move on to tendons and ligaments. And first, talking about tendinopathy, we'll talk about the volar plate. Um, and we'll talk about I think we're going to start with that with the tendons, but we'll also talk about the volar plate, musculotendinous junction, and muscles. So let's start with the tendons. We'll talk about anatomy, then we'll go to the extensor tendons, flexor tendons, carpal tunnel syndrome, and fingers. So if we look at the extensor tendons, you can divide the area of anatomy into 8 zones, with the first zone being the distal interphalangeal joints, and the 8th zone really being the distal aspect of the forearm. So why don't we'll start proximally and work distally at looking at some of the key anatomy in these different zones. So in zone 8, and this is a nice review from Clevero in radiographics, the pathologies has to do with muscles usually and the musculotendinous junctions. Injuries typically are penetrating injuries, and MR is really helpful in evaluating the extent of injury to the tendons and to the deep muscles. One pathology that occurs here is called intersection syndrome, of which there are actually 2. The most common one, is proximal intersection, and it occurs where the tendons of the second extensor compartment cross over, or cross under, in this case, the tendons of the first extensor compartment here in the distal forearm. And if you do a lot of overuse of the hands, especially twisting activities, this can produce a frictional tenosynovitis in this location, and it can be painful. That anatomy, if we are proximal from the wrist here, we can see here's the radius, here's the distal ulna, here's the extensor carpi radialis, longus, and brevis in the second extensor compartment. Here are the 2 major tendons in the first extensor compartment, the extensor pollicis brevis and adductor pollicis longus. Now they start out here with the first extensor compartment radially located with respect to the second extensor compartment, but the muscles of the extensor pollicis brevis and adductor pollicis longus are more medially located, so they have to cross over one another in the distal forearm. And here we can see on the MR scan, as we go a little bit more distally, we can see the first extensor compartments crossing over the second extensor compartment tendons. And here we can see as we head there. And then what you can see, that's normal anatomy. When you have abnormality, you can get fluid in this area where you have the intersection, and sometimes increased signal intensity within the tendons. So, Elior, what do you think of this case?
Okay, so here where these first and second extensors intersect, I see tenosynovitis.
Right. So these are the first extensor tendons. These are the second extensor tendons. So I think the first are going over the top of the second. And as you said, we can see fluid in this area, which is abnormal. And if we go to the...
I'm not sure you can say tenosynovitis. You can say that there's fluid there.
Okay. Yeah. Okay. And this patient had intersection syndrome. And this is the more proximal of the 2, but the more common of the 2. Okay, Tayson.
All right. Guess these coronals and sagittals are showing us this first flexor tendon sheath here. And I guess the crossover of the second There's some fluid in the tendon sheaths, so
Yeah.
also be worried about proximal intersection.
Yeah, and then here you can see where the two skin markers are showing the distal and proximal aspect of the patient's symptoms and pathology. And if we go to the axial images, you can see the fluid surrounding the intersection of the two groups of tendons. And again, that's acute intersection syndrome. Okay, Robert.
All right. So we have a history of forearm pain, and there's a lot of fluid surrounding the tendons there, which that's again, yeah, first and second compartments, I think. Again,
See a lot of fluid there.
yep.
Probably it would be better to say consistent with.
Okay.
Mm-hmm.
But these are the characteristic findings. And here we can see fluid extending into the tendon sheaths of both of those two compartments.
Right. So.
And then here are the coronal images.
Yeah, it looks like there's a lot of fluid surrounding the tendon. So yeah.
Right in through here. And then here are the sagittal images where you can see the fluid and the intersection of the two tendons across each other. So intersection syndrome, the first and second compartment. There's the proximal one that we've just shown, the distal one that we'll show in a minute, which is a little bit less common. John?
I'm not sure I would use the word a lot of fluid.
Okay, what would you use?
I would say there's fluid.
Okay. All right.
And then I guess a diagnosis,
Okay.
synovitis or something of that sort.
All right.
But when you say a lot of fluid, that could be like a pound or so.
Well, I don't think we'd use the term a lot in a report.
No, I know. But if we're going to be formal in a report, you got to be a little careful how you put it.
Good. I agree.
We got to be a little lawyerly about it.
Okay. So the intersection, it comes from inflammation resulting from friction between the two tendons as they rub against each other. You get tenderness, erythema, and edema in the area of the pathology. In this case, they say it's worth with flexion and extension. Treatment is usually conservative by non-steroidal anti-inflammatory drugs, stopping the activity, and maybe ice. And rarely there's surgical treatment in refractive cases.
Splinting, elevation, and ice works pretty good.
Good. Okay. Then we go to zone 7. This is the area of the wrist. We can see the extensor compartments here. Injuries are typically from penetrating injuries, and MR is very helpful at localizing the injuries. So you're all pretty familiar with this kind of diagram. This shows the 6 extensor compartments, starting on the radial side with the first, which extensor pollicis brevis and adductor pollicis longus that we've been talking about, and the extensor carpi tendons, and the second, the extensor pollicis longus that we'll talk about soon, and the third compartment. The fourth compartment are the second through fifth extensor tendons. The fifth compartment is the extensor digitorum, extensor digiti minimi tendon, and the sixth extensor compartment is the extensor carpi tendon. And this is an old MR scan showing first, second, third, fourth, fifth, and sixth compartments. Who's next? I don't remember.
I think I am.
Okay.
Okay, 24-year-old male with hand pain. I'm
Do
not,
you think that that is a proper description of what we're looking at?
no, I don't. I think we're we're too proximal.
I think you're right.
Um, okay, I see. I
So
think a
let's
muscle
just
there. That,
concentrate here on in this case, the fourth extensor compartment. Again,
Mhm.
first, second, third. This is the fourth, and what we're seeing in the fourth extensor compartment.
Yeah, we're seeing muscle involving the fourth extensor compartment. I think it's extending too distally.
Right. And then we can see that this is that fourth extensor tendons, and then there should only have tendons in the actual compartment itself, and we see muscle as extending distally all the way to the metacarpal bones. And this is a variant called the extensor digitorum brevis manus. And as we've talked about before, typical the sheaths for the tendons are not designed to handle the volume of bulk muscle, and so you can get symptoms of muscle compression, ischemia, and patients who have these kind of uh, congenital variants. Often you'll get edema within the muscle. So if we look at the extensor tendons, if we see disease, typically fluid and increased signal intensity within the tendons with fluid around them in the tendon sheath, which we typically call tenosynovitis. If it's in the first compartment, it's called Quervain syndrome that we'll talk about in a minute. If it's in the second compartment, you can get tenosynovitis also, but in the second compartment, more commonly, you'll get the distal intersection syndrome, which is called Oarman syndrome that we'll talk about. The third compartment, you can get abnormalities of the extensor pollicis longus that can be due to hypertrophy of Lister's tubercle and mass effect by the tubercle. And then the fourth and fifth compartments, you typically get tenosynovitis or ruptures of the tendon. In the sixth compartment, you get ECU, and we see a lot of degenerative disease and sometimes longitudinal split tears. So, Taysom, what do you think of this case?
All right. Let's see.
And the area of concern is actually over here.
Okay. Looks like we definitely have tendinosis of the first extensor compartment. Not any significant fluid in there though.
Okay, so I would agree with you there. Now, if you look at the anatomy of the first extensor compartment, typically you have two tendons, but actually quite commonly each tendon can be multiple. So sometimes often you have two, sometimes you can have three or even four tendons in that tendon sheath. And then between the tendons, sometimes you can have compartments and other times not. Sometimes it can just be a single space. Other times, if you put contrast in or inject or do arthroscopy, you'll find that there'll actually be segmentation within that first extensor compartment. So there's a lot of variation in this particular compartment. It means that if you try to inject steroids to treat it, you may have to be careful. You may have to put in contrast to make sure that you get into the right compartment of the tendon that may be involved. And if you try to do a release, you have to be careful to make sure that the anatomy doesn't cause difficulty with releases. Here's an ultrasound showing the tendon, which we saw was enlarged on the MR. In this particular case, with the ultrasound, we can get higher resolution and see some separation between different tendons within the tendon sheath here. So you can see kind of multiple compartments. Let's see, yeah. And well, I don't see the surgery. Yeah. Anyway, and then here we can see, nope. This was a patient who had subcompartmentalization. They went into surgery and found that there are two compartments within the first extensor compartment. Robert.
All right, so the history says radial wrist pain, and there's a marker over the radial aspect of the wrist. And looking at that first extensor compartment, the tendons look like they're a little thick and increased in signal, and there's some surrounding fluid. So I'd be concerned about Quervains.
Right. And so this is typically what you can see. Here we can see that it looks like there are multiple groups of fibrous tissue here in the first extensor compartment with increased signal intensity. Certainly on the T1 weighted image here, there's marked abnormal signal intensity and morphology of the tendons, and we see a lot of fluid surrounding it. So this is typically what you see in de Quervain syndrome, who just historically was a French surgeon, first described this disease in 1895.
I've operated on quite a few of these, and you always wonder about how many tendons you're going to run into. So you have to be very careful that you see what you're cutting. Some people think they can do it blind, but that's not a good idea.
Thanks, John. It has a lot of other names. It's basically an overuse syndrome of the of the tendons of the thumb there. And you can kind of get a catching or snapping sensation. And the clinical test for it is a Finkelstein test, where you basically put the thumb underneath the fingers, and then you do an ulnar deviation, and it produces stretching and pain in the area of the tenosynovitis.
You know, what I do is I pull on the thumb down and into the ulnar position and press on a compartment. And that usually tells you. There usually is some swelling also, and maybe redness, but that doesn't tell you how many tendons there are.
Yeah.
That's one of the problems we used to have before MR.
Okay. So, and they did a study here looking at the association between texting on cell phones and positive Finkelstein test, and you can see that if you have less than 50 tweets, or texts, it's uncommon to get a positive Finkelstein test, but as you go over 50 to more than 200, the likelihood of getting de Quervain syndrome, it goes up substantially.
The main thing is that the pain and tenderness, and then the Finkelstein test is a so-called. It's a proof that that's what the condition is.
Okay.
I'm not sure that's true though.
Okay. And then a lot of different treatments, splinting, non-steroidals, obviously stop the activity, steroid injections people use, physical therapy, and in refractory cases, you can do surgery.
Cortisone usually works, and rest, in other words, splint.
Good.
And maybe it's not the cortisone that does the job. Maybe the splinting and the rest does the job.
Okay. Good. Yes. Elior.
All right, so here looking at that first extensor.
I've got to throw in the requisite low field studies.
Mm-hmm.
Aren't you glad you guys don't read a lot of these anymore?
Yes. Yeah, it's very indistinct, those first extensor tendons there by that distal radius. Be worried about tendinosis.
And then here we can see it's hard to even see the tendons, maybe one right here, but still abnormal signal intensity within it. A lot of synovial thickening in the tendon compatible with chronic tenosynovitis. In this case, we don't see a lot of fluid, but a lot of synovial thickening. And this was a patient with de Quervain syndrome. Okay. Tayson.
All right, so looks like we have tendinosis and mild tenosynovitis of the first extensor compartment.
Okay, so we see the two tendons there, abnormal signal, and fluid, abnormal amount of fluid surrounding the tendons. And here we can see more extensive tendinopathy of one tendons, and we actually see three different structures, as we know about as common within that coming out of the first extensor compartment with a lot of surrounding fluid. Again, typical of deep Quervain's syndrome. Okay, Robert.
All right. Here we have a marker over, I believe that's a second extensor compartment.
Yeah, this is the second. This would be the first over here.
Mhm.
Fourth, fifth, and sixth is over here.
And yeah, looking at one of those two tendons, the one on the left, it looks a little bit kind of some partial tearing there.
Yeah. Here, the little bit more distal. Yeah. The next cut.
The next looks like there's some fluid surrounding the adjacent tendon.
Yeah. Here we're a little bit more distal. And this is a partial tear of the ECRB. If we go back here, this is actually part of the ECRB comes over the second compartment, and we should see a tendon coming in here, which going into the third compartment. We'll show this anatomy a little bit better. And this turned out to be a high-grade partial tear. I think it was from a penetrating injury of the extensor pollicis longus tendon. And one of the easiest things to miss in the wrist is when you have a complete tear and there's no tendon. So kind of looking again at the tendons here. Here's the first extensor tendons coming across here. The second extensor tendons coming here. The third extensor tendon, which is extensor pollicis longus, coming across here. And then again, you can get intersection syndromes here and here. And then the fourth are the bulk of the extensor tendons here. The fifth is the extensor digiti minimi, and then the extensor carpi radialis over here. So let's see. Elior, is it your turn?
Yes. So here we see fluid in the tendon sheath of the extensor pollicis longus, and also within the second extensor tendon, so concerning for intersection syndrome.
Okay. And then here, this is just a video showing multiple adjacent images as we go out here. So let's start again distally, and this is the extensor pollicis longus tendon. Notice how thickened and increased signal intensity it gets. Then it goes into by Lister's tubercle into the third extensor compartment. So this would be a distal intersection syndrome, but primarily a high-grade partial tear of the extensor pollicis longus tendon here with some tenosynovitis of the extensor carpi tendons. Okay, Tayson. Another old low field scanner.
All right. Adjacent to Lister's tubercle, where I expect to see the extensor pollicis longus, I don't see a tendon there. So I'd be worried there's a high grade or complete tear.
Good. And that was a complete tear of the extensor pollicis longus. And if you get a good history, which we frequently don't, these patients almost always have difficulty extending the thumb. Okay, Robert.
All right, so we have a 14-year-old male, dorsal pain for 2 months after trauma. Rule out TFCC tear. we're out of the plane of the TFCC, and we're looking at the extensor compartment.
Okay. I
And
see a
I
little
don't,
marker back here.
yeah, I see a marker back there too. There's an arrow getting over to, is that the EPL?
Okay.
And tracking it more proximally, it looks intact still. That's still intact, I think. Yep. And yeah, there, I think it's still intact.
So
Looks a little,
why does this patient have dorsal pain?
I mean, he could have an intersection syndrome, but I don't see a whole lot of surrounding edema or fluid.
Right. Yeah. This patient had trauma. uh, if we go back here, and then uh, this is if we go back to the level of Lister's tubercle, and what you actually see that these are the first extensor tendons, second extensor tendons, the extensor pollicis longus or third extensor tendon, but the third extensor compartment is over here. This patient had trauma which caused a displacement of the EPL out of the third extensor compartment across Lister's tubercle to the other side. So this patient had a traumatic displacement of the extensor pollicis longus, and that was the cause of the patient's symptoms. Okay, Elior.
Okay, so let me see. Radial aspect. Oh, okay, where the circle is, I think that's the extensor pollicis longus tendon.
And here's a marker.
Mm-hmm.
This is a little bit more proximal.
Okay. I think it's
Right
intact
distal.
still.
Okay.
Yeah, it's coming. Okay, so that's it. Okay,
That's it.
maybe torn there.
Yeah. And then here we go more proximal. We can see edema within the dorsal aspect of the radius.
Mm-hmm.
And this patient had a complete tear of the extensor pollicis longus and had a traumatic impaction injury to the dorsal radius. And we don't see any extensor pollicis longus in here.
Now what you have to do is look to see where it winds up.
Right. And so that's right. Then it's the job on us is to find how far approximately the tendon has retracted. Okay, Tayson.
All right, so a lot of fluid in the tendon sheath. I'm guessing the extensor pollicis. It looks intact though.
Okay, so here we go. Now this is over on the radial side. Yeah. But this turned out if you followed it all the way down, so you know you can't. Let's have you do another one. If you follow this all the way down, this would be in the along the extensor pollicis longus, and this was tenosynovitis due to overuse. Why don't you take this one instead?
All right, so looks like there's a surgical tunnel there in the is a third.
And there we can see the marker there. So what do you think's going on here?
Guess that's been repaired.
Yeah, this was a. If we follow all the way back, this was the extensor pollicis longus. Now this was a tenodesis of the extensor pollicis longus into the third metacarpal base. Robert.
All right, so we have a 17-year-old male with thumb pain for 4 weeks after injury. Looking at that IP joint dorsally, there's a lot of soft tissue edema. I can't really see the distal insertion of the EPL, so I'd be concerned about at least a tear there.
If you follow it down, that's right. So this was there's no retraction of the tendon, so this was a high-grade partial tear at its insertion. Okay, Elior.
Okay, we have an 80-year-old female with rheumatoid arthritis. Yeah, looking for the EPL, certainly doesn't have as dark signal as the other tendons.
Are you talking about here?
Yeah,
And
if
what do you think
that is what
about
it is.
what do you think about the tendons in the fourth and fifth extensor compartments?
Yeah, similarly, they don't have that normal dark signal. Could be tendinosis, could be torn. ECU that looks subluxed.
Yeah. And so if we look here, we can actually see that there's as you say, the EPL is abnormal. The extensor tendons in the fourth extensor compartment, there's kind of a clump of tendons here, but it looks like some of them are missing. The extensor digiti looks like it's missing, and the extensor pollicis is dislocated. And this patient was unable to extend the fingers due to hairs. So with rheumatoid arthritis, with chronic inflammation, it starts disrupting the collagen fibers of tendons, and it can lead to tendon ruptures, which is what occurred in this particular case. Hopefully, nowadays that we have effective treatments for rheumatoid arthritis, we won't be seeing this anymore. And this just shows the tear here with retraction. Okay. Tayson.
All right, so overlying that, I guess fifth extensor compartment, there's a synovial fluid.
Well, this is the fourth here. That's probably the fifth. And if we follow this back, we can see that that extensor tendon looks very abnormal.
Yeah.
And here it looks kind of gone. And here, this is in the area of the fifth extensor compartment. If we go here, we can see that there's a rupture of the tendon. And this was a rupture of the fifth of the extensor digitorum minimi tendon in the fifth extensor compartment.
You can repair these um, by connecting the two or three together, and it'll work in terms of extension. If you look at your hand and extend the fingers, you notice that you can extend so many fingers at one time. There's always a difference in most people's hands.
Yeah. And that's, I think, we'll show the anatomy in a minute. The extensor tendons, a little bit more proximally in the palm of the hand, the extensor tendons are actually interconnected. So you can't really, it's difficult to extend one tendon markedly without extending all the others because of
Right.
that. And then here we can see fluid and an abnormal tendon within the fifth extensor compartment here.
If you look at the anatomy, you see the connection between the tendons.
Yeah. I think I'll show that later. Okay, Robert.
All right, so we have a 45-year-old female unable to extend the little finger after injury. Let's see. Looking at the fifth extensor compartment area, it looks like there's a lot of soft tissue infiltration there, edema. There it looks like there may be some tendon there, so I'd be concerned about a tear. And yeah, it just looks thickened and irregular and torn, really. Yeah, there it looks very lax and completely torn.
Yeah, so that was a tear. And here you can see that's actually buckled back on itself. So this was a complete rupture of the, the extensor digiti minimi tendon. And if we go to the sixth extensor compartment, it's a little bit different from the others, as you all already know. You have the outer covering is the extensor retinaculum, which is attached to the ulna bone on either side of the sixth compartment. Inside that, you've got a subsheath, and then inside of that, you have the tendon and the synovium. And then obviously here's the ulnar styloid, and this is the ulnar head. This is a common, tennis players commonly get injuries of the extensor carpio-ulnaris tendon. They can develop tendinopathy, traumatic instability, or complete rupture of the tendon. Kind of looking at it, here's the tendon fibers itself coming down here. You can see the longitudinal type 1 collagen fibers here. We can see there's the ulnar bone right there, and then these fine sheet of fibrous tissue across here is the subsheath with the sixth extensor compartment opened up here. And this just shows it moves around a little bit with supination and pronation, as we have already talked about. So here's just a case where you have trauma and a tear of the retinaculum in this particular patient. Probably either a congenital bifid or a longitudinal split tear. We'll talk more about that in a little bit. And this is a patient who, when they were, this is the same. Oh, let me just go through this. That's right. So this is a patient who, this is, if you go from pronation to supination, what ends up happening when you go to, you actually get motion of the tendon. And in this case, since the subsheath is torn and the retinaculum is torn, we're getting a displacement, an instability of the extensor carpio-ulnaris tendon. So if you're really concerned about instability, some people will do pronation and supination images, especially imaging the patient and the position where they feel the popping and the symptoms. Okay, see, I don't remember who's next. Who's next?
It's me.
Okay.
Yeah, I see a lot of edema in the ulnar side of the wrist, dorsal wrist. That ECU looks like a split tear.
And right here.
Mm-hmm.
And longitudinally, we can see it coming down through here. This patient actually symptoms were not thought to be due to this. This was thought to be a congenital bifid ECU because it's nice and smooth. But I don't think we can always differentiate between the congenital varieties and longitudinal split tears with MR alone. But this was thought to be a congenital bifid one. This, on the other hand, was a patient who was symptomatic. This one is not so smooth. It's more irregular. And this is a patient who had a surgically proven tear of the retinaculum and the subsheath and a longitudinal split tear of the ECU. And it's much more prominent here on the sagittal images. Okay, Tayson.
All right, so prominent fluid in the extensor carpio-ulnaris sheath. Distal attachment, maybe a little overestimated by some volume averaging, but looks a little attenuated at the distal attachment.
Yeah, I think it's the partial voluming there getting a little out of the plane. And this is a patient who had ACU tenosynovitis. And here's another example on a lower field scanner showing the extensive amount of fluid here in the tendon sheath. and someone who also had tenosynovitis. And here we can see a little bit of subluxation of the tendon with a little bit of signal within the tendon. And this was instability of the ECU. Again, I think I said this before, but this is very common in older individuals who have rheumatoid arthritis. And in rheumatoid patients, this is typically not symptomatic. And young athletes, it would be very symptomatic. Okay, Robert.
All right, here looking at the ECU again, it looks like it's dislocated and some fluid surrounding the tendon, tenosynovitis.
Right, and then what's happening here and here?
Yeah, there's an effusion with some synovitis, some tenosynovitis of the.
And probably some synovial thickening in the fourth extensor compartment as well, and in the fifth. So, what do you think's going on to this patient?
I mean, I suspect like a rheumatoid arthritis kind of picture.
Yeah, this is a patient with rheumatoid arthritis. And the typical dislocation or subluxation of the ECU in patients with rheumatoid. John?
A lot of these tendons, instead of trying to make a sling out of the tendon sheath, you tendonitis it to the bone.
Okay. Okay, Elior.
All right, so looking at the ECU, it is subluxed out of this ECU groove. Be concerned for a retinacular tear.
Yeah. Yeah, and a lot of tendinopathy of that tendon. This is also a patient with rheumatoid arthritis. Okay, Tayson?
Looks like the groove for the extensor carpio-ulnaris tendon is empty. Be concerned for a rupture.
Yeah, and then a lot of tenosynovitis in the second and other compartments here. And then this was actually if we had all the images, you could see this was the dislocated ECU here. And again, this is another patient with rheumatoid arthritis. Okay, Robert?
So we have an 81-year-old female with RA. I mean, I see a DRUJ effusion, and I don't see an ECU tendon here, so I'd be concerned it's torn and retracted.
Okay, and here we can see that area. Yeah, and that was completely torn and retracted. Good. Elior.
21-year-old male, 1.5 years after ECU surgery for repetitive work trauma. Yeah, we see along that distal ulna, they maybe some suture anchors there. The tendon maybe is being tacked down.
Yeah.
The ECU looks pretty good there in the groove.
Yeah. And then, yeah, this was surgery for ECU instability. Good. And then here we can see a suture anchor. In this case, the patient still has some subluxation of the ECU and certainly abnormal morphology, and that's a suture anchor placement to try to stabilize it. Okay, John, did you want to say something?
Tendonitis, like I said, is a simple procedure, and it usually works.
Okay.
Some other procedures with the fascia that just a waste of time.
Okay. Tayson.
So the extensor carpio-ulnaris is subluxed ulnar and flattened over the distal ulna there. All right, so some susceptibility artifact. Yeah, maybe it was operated on as well. Tenodesis.
Yeah, spinal
Yeah,
artifact.
this looks like a tendonitis.
Uh,
Oh, okay, yeah.
I'm not sure. I'd have to, with the other images, we could differentiate that. I'm not sure whether this is a tenodesis or whether there was a repair of the retinaculum.
Well, the reason I say that is because the bone has been removed to cancel this bone
Okay.
of the ulna, and you wouldn't do that if you um, try to fix that um,
Okay. There's just a
fracture.
lot of distortion in this area due to the metal
Yeah.
from the suture
But
actor. Okay. But that's just another.
I myself would just drill some holes and just put sutures through the tendon.
Okay.
It's cheaper and works just as well, if not better.
Okay. Robert.
All right, so here, looking at the ECU, it looks like there's some increased signal there, but there's a lot of surrounding synovial thickening and soft tissue edema.
Yeah. Right. Yeah, and then if we go,
Looks like synovial tissue, John.
yeah, that's a lot of synovial tissue, a lot of synovial thickening, probably some longitudinal split tearing of the tendon. If we go more distally, we don't really see the tendon well at all at the level of the sixth extensor compartment. And this is a patient who had a complete rupture, and that was all synovitis from rheumatoid arthritis. Okay, let's see. Why don't we stop here, and we'll start zone 6 next week. I mean tomorrow and Friday. Okay.
Thank you.
Okay.
Thanks, everyone.
Have a good
Thank you.
afternoon, everybody.
Thanks, you too.
You too. Thanks.
Take care, guys.
Yeah.